Live. Okay, I'm a few minutes late this evening, but I'm here. So for those of you watching the replay, thank you as always for watching the replay. Go ahead and give me a shout out in the comments section. Say replay, say hey Cosi, say Cosi, this is my question, answer it. I do go back and look at the comments after the show's closed to make sure I have any questions that need to be answered by folks watching the replay. I'm going to give you guys a couple minutes to jump on board, and I'm just going to make sure my audio is hopefully where it should be. Just checking everything right now, and it looks like it's all good. Woohoo! All right, guys, so happy All Saints Day. I know we had a lot of fun last night with trick-or-treating with the kids. All right, I see a couple of y'all jumping on board. When you jump on board, don't be shy. Let me know who you are, where you're from, and what's in your glass. And as you can see, I'm breaking my own rules this evening. I just have a boring old glass of water. I didn't have time to get myself a good drink. Hey, Emily from Inpatient Rehab. Emily, I know you are working so hard. And Emily, I have your questions here this evening. I know we weren't able to get to them last Wednesday with Ronnie, but we've got them here today. We've got David here in South Carolina drinking his green tea. All right, guys. Oh, and you got your hot chocolate today. I know we're getting a little bit of a cold front coming in now pretty soon in the next couple of days, so everybody's busting out with the hot chocolate. All right, guys, I know I'm running a couple minutes late, so I'm gonna give you guys a minute or two to jump on board. All right. Did anybody get the message, the text message? Did you guys see Bob here on our date night last night? He's still recovering. All right, we got Kesha coming in from California. Missouri, California or Missouri? Where are you from, Kesha? You're drinking berry flavored Propel. All right. Guys, don't be shy. Let me know. There we go. Cold in Florida. Yes. We sometimes do break 80 degrees here, Emily. I'm just saying it can get downright chilly here. We got Scott coming in from West Virginia, drinking his root beer zero. All right, Scott, how is it going with your socket? Give me a quick update if you can. All right. We got Steven Schreidel in Michigan. Oh my gosh, snow already. That's insane. So guys, I'm actually going to be speaking at a conference this weekend. I'm so excited about it. It's my third time being the keynote speaker for this conference, and I can't say how excited I am. It's the Discover Your Possible event that is being put on by Mission Gate organization. I have to give a shout out to the folks over at Mission Gate, David and Carolyn Lawrence, Robin Yoder. They have been so wonderful. David created this organization as a way to help educate physical therapists on every aspect of gait training, with a huge focus on amputee care, on amputee gait training. And then Robin brought me into the fold to be a participant in this event, and I'm so excited about that. So you guys are going to be seeing hopefully some pictures on social media of my travels going to Richmond, Virginia, and there's a couple of you that I'll be able to actually give a hug to in person again, some old friends and hopefully new faces as well. So I'm really excited about that. We got Kay's coming in from Canada, but now she's in Key Largo. I'll bet you're enjoying that a lot more. We've got Eric in from Oregon with his 7-Up. Andrea, oh my gosh, Andrea, I'm gonna need your help tonight. There is a question on here that it's got occupational therapy written all over it. So Andrea, don't fall asleep yet, stick around. I know, and it was so nice that it was below 70 degrees here in Florida. That's like, a blizzard here for us. Let's see. Scott says it's going good, much better fit, should be clear for therapy end of month. Yes, awesome, Scott. We got Susan coming in from Canada. We got Harsh. Harsh, am I gonna see you this weekend? I wanna catch up. Let's see. Susan says it's freezing in Ontario. Yep. Let's see. Thank you, Harsh. And then we've got Kay's saying 3 feet of snow. Y'all are getting too much snow. That's why I live here in Florida. No snow. I am getting there on Friday, Harsh, and the event is on Saturday. So I'm getting there early Friday morning, and Robin is going to be shuttling me around to different places to do different things. So I'm really excited to get to see you again on Saturday. All right, guys, let's go ahead and get started. For those of you who are new to the show, my name is Cosi Belloso. I'm a physical therapist, amputee specialist. I've been a PT now for 23 years. And I was thinking about it, I was like 23 years as a physical therapist, but almost 30 years in healthcare. I'm not going to tell you how old I am. Okay. And obviously my passion is working with the amputee and limb loss community. So guys, it's interesting. I've had a lot of new folks reach out to me on my texting service and also on my email. And I want to just go ahead and put that up there for now. So I'm going to put the texting service because I am using it a lot more to communicate with y'all. So if you're not on there, get. So all you have to do is text Cosi Talks, all caps, just like that, to that number, and you'll get my text alerts. And I promise I don't spam any of the text messages or anything like that. But this is a way for you guys, and you guys can also text me back your questions, and I've been doing that. Those of you who are texting me, if you don't mind writing your name in the text message so I know who it is that I'm talking to, that would be great. And guys, a special thank you to those of you who participated in the polls that I've been putting out there and the questions I've been putting out there. A lot of times my sponsors will have questions. So my sponsors this year were Integrum, College Park Industries, Prosthetic Orthotic and Associates of Tennessee, and Click Medical. Right? And part of what I do for my sponsors in gratitude for their support of the show is I try to help them know what it is that your needs are. And it's kind of a two-way street in terms of help. Because a lot of times my sponsors want to know. They want to know what is going through your mind as an amputee. They want to know what are your needs, what are things that are obstacles in your life so that they can improve upon whatever product, whatever service it is that they're offering. So in the next week or two, you're going to see me posting a lot of questions and polls. And truly, it helps you to answer these questions because you're letting them know what you need. It helps me because it shows the engagement that I have on the show, and it helps my sponsors. So truly, truly appreciate any help you guys can give with that whenever you see one of my Cosi polls. And I've got a couple of more coming out in the next week or two, so keep your eyes open for that. Okay, here we go. Let's get started. This question was actually from a while back, and I hope, Ryan, that you're on board tonight because I finally was able to sit down at my computer and do some reading. So Ryan had asked a while back, would Botox be effective on a hip flexion contracture, right? So let's go ahead and just do a quick review on what it means to have a hip flexion contracture. Okay, so here's Bob, poor Bob. I think he's still recovering from last night's festivities. I don't know, you guys saw that picture on social media, right? So anyways, quick anatomy lesson. I've got to point him the right way. All right, so here on the inner part of our pelvis, we have a big muscle. It's called the iliopsoas muscle, and it's actually a combination of two muscles, the ilius and the psoas muscle, right? It's a really big, wide, broad muscle, and it starts here and it ends somewhere around here. So it's very broad and wide, but it's short, okay? Big, beefy muscle, okay? So when you have your amputation, right, whether it's a below the knee, above the knee, higher up, okay, this muscle tends to overpower things. And what do I mean by that? Well, since you no longer have the weight of your lower leg to keep your leg down, to keep it nice and straight in extension like this, right? That big, powerful iliopsoas muscle is going to start to make that leg creep up like this. Right? And it makes it difficult for the amputee to be able to extend their leg. And we call this having this tightness can turn into a hip flexion contracture. So many of you, especially my above the knee amputees, might remember those early days in your surgery where hopefully the physical therapist and the nursing staff were teaching you how to position your leg flat in the bed. Okay? So flat in the bed with nothing underneath it that would cause this tightness to start to happen, okay? And not just flat in the bed, but also prevent it from rolling out to the side because you can get tightness on the side as well, okay? But, you know, even sometimes with the best of intentions and the best preventative care, you start to develop some tightness there, okay? That can develop into a contracture, right? So there's two basic kinds of contracture. There's the fixed and then there's the pliable. I call it the non-fixed, right? So with a contracture that's not fixed, meaning it means it's still pliable. It means there's still play there in the tendon of the muscle. There's still play there also in the muscle fibers, right? So with intense physical therapy, you can get that muscle to lengthen again, okay? With a fixed contracture, It means that it has undergone changes, usually calcification of that tendon, and it kind of, for lack of a better word, just kind of hardens up, right? And in that case, there's no amount of physical therapy or cranking on there that's going to stretch out that muscle. In fact, if you start cranking on a fixed contracture like that, you could actually cause damage to other structures, because once that thing is fixed, it's not moving, and it may require surgery, okay, in certain cases, extreme cases, okay? So with regards to Botox, right, Botox is botulism. It's a bacteria, right? And part of what it's used for is for muscle paralysis. We see, you know, in Hollywood celebrities that they'll put it all over their face to paralyze the muscles in their faces to prevent wrinkles from happening, right? So other uses of Botox have been to inject into spastic muscles that have a high amount of tone to it, a lot of spasticity. I know I've seen it back when I worked with the pediatric population with our children with cerebral palsy that had a lot of high tone, right? And I have used it occasionally used in grown-ups and adults who have had traumatic brain injuries and they have severe spasticity. When it comes to use in a hip flexion contracture, yes, I did find literature showing that it was used in cases with hip flexion contracture with some success. I, however, was not able to find any literature that said on fixed contractures, okay? So remember what I said the difference. The fixed contracture means you've got calcifications going on in that tendon and that thing is not moving. You're gonna have to have surgery to release that muscle again, okay? So with the non-fixed, yes, you can use Botox as an option to perhaps get a little bit more length in that muscle, okay? But I guess the other flip side to that is you got to be careful, because if you're adding a paralytic agent to that muscle, making sure it doesn't compromise the motor part, right? So this is just, it was an interesting question, and it was something that I had to go and just look up a little bit more literature on that. All right, we got some comments coming in. Susan, did I see your resin socket? Susan, you know what? I remember somebody sending me a message about that. Can you resend it to me, Susan? That may have been one that slipped through the cracks for me. Hey, Jen. Hey, David. Kesha asks, I have an appointment recently with my leg doctor. We discussed getting an adjustment socket, and he's wanting to put me in a device that goes up to my hip for a BK. What is your opinion on this? Okay, so Kesha, did he explain why he wants you to have a device that goes up to your hip? So here's the thing, guys. I love doctors. I think they're good people. Lots of them friends, lots of family members who are doctors. But when it comes to amputees, sometimes doctors are not necessarily up to date when it comes to explaining prosthetic devices. Now, there are some exceptions to that. For example, Dr. Shu, he was on my show just a couple of months back, and a couple of the surgeons that I've had on my show where they work with amputees day in and day out. So they are very familiar with a lot of the prosthetic componentry. So Kesha, I just wonder if perhaps your doctor didn't communicate things very clearly. I don't know, trying to play Monday morning quarterback. Typically for a below the knee amputee, you do not go all the way up to the hip with the device, okay? So you'll have the socket, right? And the socket, come here, Bob, you're not done yet, buddy. All right. So typically with the below the knee socket, so if your amputation was, midway through your tibia, the socket will cover the rest of the residual limb, okay? And it will come up to the knee. Okay, it won't go past the knee because you want to be able to utilize and bend that knee, right, Kesha? Now, what might happen sometimes is sometimes they'll put what's called a suspension sleeve. It's like a neoprene, a very flexible material, kind of like scuba diving suit material, feels like. And they might put that over your knee and roll it up to your thigh to help keep the suspension of the socket, to help keep your socket on your leg, okay? I'm not sure why your doctor would want you to use a device that goes all the way up to your hip. Again, could it be that you have some instability in your residual knee and maybe it needs a little bit of extra bracing there? That's the only thing I can kind of think of. So I just wonder if perhaps your doctor, perhaps he or she doesn't understand how a prosthesis fits. And maybe it's a doctor that is very good at the surgical amputation side of it, but perhaps doesn't necessarily know the prosthetic side of things, right? It's interesting because a lot of times surgeons, I've had a lot of surgeons tell me, they go, well, if all goes well with my patient, I sign off on them at 6 weeks and that's it. That's the last I see of them. After that, it's up to the prosthetist and physical therapist to keep the treatment going. There are exceptions. Those of you who are followed by PM&R doctors or centers of excellence like the one they have in Atrium, those are different cases. So Kesha, I hope that answers your question. And as far as an adjustable socket, yes, I do like adjustable sockets. However, Kesha, I would really think that's a better conversation for you to have with your prosthetist and your physical therapist. Again, the physical therapist is the one that knows how to really piece together what you will need from a functional mobility standpoint, right? We're the ones that can analyze how your mobility is doing and give input on what would be good prosthetic componentry, whether it's an adjustable socket or a particular knee or particular foot, right? And the prosthetist input is obviously very important as well to determine what's going to be the best fit for you. So adjustable socket technology, I love it. I've had them on my show a lot. Love it. And I think it's worth having a conversation. Do I think it's meant for everybody? No, because there's no one fit for everybody. But I think it's worth having a conversation. Hope that answered your question there, Kesha. Hey there, Hope from Colorado. All right. Hey, Jody. Jody, I haven't seen you in a while. We're coming in from Las Vegas. We got Tom watching from Peekskill, New York, heading to the Big Apple tomorrow. Tom, getting ready to run your marathon. That's so exciting. Thank you, Susan. Yes, please resend me the email. Oh, good. So Linda said, just had my Botox injections yesterday. I've had great results with them. Linda, are you using them for sweat management? Because that's the other thing that we've seen in the literature is that in extreme cases of extreme sweating, hyperhidrosis, right? Where there's a lot of sweating going on in the residual limb and it's interfering with the ability to wear a prosthesis, they are starting to use Botox to help control the sweating. And I have a couple of you all here that do use that technique. Jeff asks, this is interesting. Have you worked with patients where their doctor prescribed Botox for hip flexion contracture? Me personally, with my own patient caseload, no, but have I seen patients, and not related to amputee, actually, the patients that I would see where the doctors prescribed Botox injections, it was usually, again, the pediatric population to help with the spasticity. And also with the adult traumatic brain injury. So adults that have just had severe spasticity, sometimes in the quads or in the hamstrings, especially the hamstrings sometimes, they would do some Botox to help relax those muscles and to allow the physical therapist to really get in there and try to get some of that range of motion back. But interestingly enough, I don't think I've had an actual amputee who's had Botox for hip flexion contracture, but it's applicable. It's applicable. Right? Oh, that's a good point, Jeff. So Kesha he's saying that perhaps Kesha is a short below the knee amputee, maybe requiring a thigh corset, right? Something extra for suspension. That was kind of what in my mind. I was like, well, maybe he was referring to some suspension sleeve, and if the doctor not very familiar with prosthesis, the doctor might think that sleeve goes all the way up to the hip, and that's not the case, unless it again is a very short residual limb. So Kesha says, my doctor used to be a VA doctor and he wants to be safe than sorry because I'm having problems with changing size so much due to weight loss. Okay, so Kesha, hang on, hold that thought. This is the one I want. Okay, so Kesha, it's two different things that your doctor, I think, is trying to talk to you about. And it's really important that you understand the difference between the two. The first part of it is suspension, meaning how is the socket held onto your leg, right? That's where the thigh component, that part that goes up the hip, I think that's the part your doctor's talking about there. Okay, and again, like Jeff said, if you have perhaps a short residual limb or a lot of, so you might need a little bit of extra suspension, okay? That's different from accommodating the changes in your limb in size, okay? So different. Suspension means how the leg is held on, right? When it comes to, make sure I get this right. If you are losing the weight and your limb is changing in size dramatically, okay, then yes, an adjustable socket might be indicated for you because it will allow you to adjust the girth. And I think that's a better way of describing it, right? The girth of the socket to make the socket smaller or bigger according to your needs. Now, does making the socket smaller help contribute to suspension and help keep the socket on? Yes, but that's not the primary thing that holds your leg on. Does that make sense, Kesha? Okay, so how the prosthetist designs the socket, right, to distribute the pressures around your limb, that's what's really going to determine how the leg is held on. Also, if they decide to use other methods such as suction or pin lock. And I actually did a talk all about suspension systems, Kesha, and if you go to my YouTube channel under the live video archive, you'll find it there, and it's labeled suspension systems, and that'll explain it a little better. So I hope that clarifies that a little bit for you. So Emily says, my below the knee socket goes up to my thigh, but it's because they had to add a leg brace to allow you to walk because she has spina bifida. So again, in Emily's case, because she does have involvement in her knee on her residual limb, she required extra bracing, which requires there to be more componentry leading up the thigh, okay? But unless there's a knee instability or something going on there, typically the suspension system is not going all the way up to the hip. So Nalitza asks, someone told me that the reason of a bone spur is because of a bad prosthetic fitting. Is that true? So there's a couple of theories. And again, Nalitza, you know what? Let me just take a moment here and put in my email. Guys, for those of you who are new to watching the show, I always like to remind people this show is for you. This show is for my amputees, for the clinicians, and for the caregivers of amputees. So I'm here to answer your questions. There is my email address, and I answer all my emails. Sometimes, like Susan knows, I have to have a little bit of a nudge, but I do answer all my emails. Nalitza, can you please email me your question? Because I do want to look up some of the literature and see what the more recent literature is saying. But just off the top of my head, typically with bone spurs, right? Bone spurs are kind of like the blisters of bones, right? When you have friction and shearing going on, there's irritation going on that bone to kind of start causing that bone spur, that extra bone formation to happen. I do remember reading that a person might be more prone to bone spurs if the periosteum was scraped during on the bone. So what's the periosteum? The periosteum is a very, very thin membrane covering of the bone. You know how when you're eating a chicken bone and you're down to the bone part and it's like a really thin little membrane? That's the periosteum, right? So I just remember reading somewhere that the periosteum can get scraped and there's a potential there for bone spur. Okay, so if on top of that your socket is not fitting properly and you're causing undue friction and shearing forces on that bone, then yeah, I think the potential it could be there to cause a bone spur. But again, that's something I want to look up and really make sure I'm telling you the right thing. Yeah, so Andrea's echoing Jeff's thoughts on Kesha having to perhaps need an extra thigh corset or something that goes up further the thigh in case she has a shorter residual limb. Hey, Leanne, thanks for the comfortable California hug. Okay, so Kesha's saying my BK is about halfway between my ankle and my knee. So it's actually not a short residual limb. That's actually a nice residual limb. So if it's halfway in between, Kesha, it could be, again, just ask your doctor to explain it to you better. And then the conversation also needs to include your prosthetist and your physical therapist, okay? When you get input from all three sources, I think that's when you have the best outcome because each one of those three parties is gonna have a different way of viewing your case and viewing what might work for you, right? So I think it's good to have the input for all three of them. And again, it could be that your doctor perhaps was not explaining things very clearly. And it happens sometimes. But I'd be curious to see what your prosthetist is saying. Howdy, Van Gregory. Let's see. Susan says, that's a nice long limb. Mine is only 3 inches below my knee, right? So someone who has a much shorter limb is going to require more effort for suspension, right? I'm guessing it's a sleeve. That's going to be my Monday morning quarterback guess. Hey, Drew. Drew says, may get my new Revo socket next Wednesday. Got to use the click reel. Very nice. Jody says, 9 weeks ago, I had a total knee replacement on my sound leg and I'm back now and I was in Utah for 2 months. Glad to hear you're back and up and on your feet, Jody. Let's see. So Linda says, with regards to the Botox injection she gets, she says, yes, it does help with phantom sensation and nerve shocks, especially with change of temperature. That's the first time I've ever heard of that, Linda. That's very interesting. Okay. Let's see. Thank you, Kesha. Feel free to email me. That's fine. So Hope says she gets dry needling for her contracture. Yeah, and there's a lot of new modalities out. And I call them new because I've been doing this for 23 years and they weren't around when I started out as a therapist 23 years ago. I like dry needling. I really do. I'd love to take a course on it. I have a couple of colleagues that are trained in dry needling. I think it's great. Let's see, RevoFit is great, still need typical care on my tibia, no skin there between the bone and the socket. Okay, so guys, let's hit the next question. We've got a question here from Emily. Andrea, this is where I'm gonna need your help. My occupational therapist, I need you to sound off for me on this one. Emily says, do you have any tricks on how to don a prosthesis easier if a person cannot use their muscles to push down into the socket? Okay. So again, this is one where I've had some really interesting cases where a person had impaired fine motor skills, they had weakness in the hands, and it was making it very difficult to put the prosthesis on, especially the liner. I always find that the liner, more than the actual prosthetic itself, can be a challenge for someone who has weakness in the hands or is lacking coordination, or perhaps they're missing sensation in their hands from neuropathy. And again, this is where I rely heavily upon my occupational therapists because they are the experts on activities of daily living such as this in terms of having any equipment and strategy. So I'm going to give Andrea a minute or two to sound off on this one, and then I'll address Emily's other question. She asks, what causes a pin lock to get stuck, and how do you get your prosthesis off if the pin lock is stuck? So pin locks, yeah, that's another love-hate relationship for me. So pin locks, again, it's like a little screw and it goes into a little hole. So sometimes if the sock getting caught, that's usually the biggest culprit. So you'll have, hang on, I think I actually have, it's new, okay. Yay, I forgot I have new toys here. Haha. Okay, so here's the pin lock. So it's attached to the liner, right? And then it goes into the socket. I forgot I had this socket here. Yay, I'm so excited, right? And then it clicks in, right? And in this case, it clicked in quite nicely because there's nothing else there. Now, for some folks, right, they might need to wear socks around here on the outside. Let me see, do I have any socks? Sorry guys, I've completely forgot I had this bag. No, I do not have any socks. Okay, so sometimes folks need to add socks on, right, to fill up the volume in case their limb was shrinking, right? So usually the biggest culprit, and I'm a stickler for this, is when the person does not pull the sock all the way up past here, okay? So do you see how there's like a little green ring right there and that little white ring? If the person just leaves the sock around here, you're going to get that thing caught in the pin lock hole. So usually I have the person really stretch it out so that the sock goes all the way down to this part and that this part is left open, right? Because all it takes is a little pinch of a sock in there and then you're sitting there trying to take this thing off. Sometimes you got to put a little bit of elbow grease in there and you can manage to get the sock out, right? All sorts of things. In extreme cases, okay, we're talking about you've been sitting there for half an hour with your patient and you cannot get this thing off, then basically what you need to do is you need to pour just a little bit of water into here, That'll release the suction and you can pull the whole thing off. And then you just have to make an appointment with your prosthetist to get the pin lock unstuck. That's only happened to me maybe once, where we simply could not get the pin lock unstuck. Yeah, usually our biggest problem with pin lock is to get the pin lock to go in. As you can see, and I know the prosthetist who made this socket, and he's an amazing prosthetist. This just clicks right in, right? It's nice and easy to do. But sometimes it can be a little bit tricky, especially if the person is still learning how to aim the pin into the little hole that it goes into, right? And if your liner is not put on properly, right? If the liner is not put on, maybe it needs to go straight up and down, right? And if it's just angled ever so slightly up, then you're not going to get the hole into the right place, right? So that's usually the problems we have with pin lock, is not getting the pin lock out, it's getting the pin lock to go in. Likewise, if the person has any swelling going on in their residual limb, it's going to make it more challenging for them to be able to get in all the way far enough to engage that pin lock. Yes? All right. Let's see. Andrea, did you answer for me, please? Yep. Andrea says it's probably one of those things that watching you try to do it would give a lot of information. The pin getting stuck is tough, usually a mechanical issue with the button. And again, I do say that if you, oh, Emily says, my prosthetist says that if you pull hard enough, it will release from the pin lock. Yeah, and that's true. Like I said, I think I've only ever had to send a patient once in my entire career back to the prosthetist because I couldn't get it out of the pin lock, okay? And we had to, pour a little water into the liner to get it to release and get it all off. And that's an extreme case. But yeah, I've had some patients who get fairly frustrated. I had one viewer tell me that he had to actually sleep the whole night with the socket on because he didn't know the trick about pouring water into it, and his pin lock got stuck. So he had to sleep with it until he could get to his prosthetist the next day. I'm like, oh dear. So Andrea is basically saying that, yeah, when it comes to someone who's having trouble putting their prosthesis on, again, I know for me, I like to see what's going on, and Andrea's echoing the same thing. See what's going on with the person, see where is the impairment, where's the deficit there. So Emily, again, it's something that I would say, I know you're in inpatient rehab right now. Have the occupational therapy work with you on this and just see where it is that they can find, just a trick or a hack to help you get that leg on by yourself. Sorry guys, I'm scrolling through these questions. Harsh says, I had to run to hanger in the past with a pin locked. Okay. And Emily says, I still have issues with getting clicked into the socket. And again, Emily, you've disclosed to us in the past that you have that lymphedema. So yes, it can be a little bit challenging if you're battling with a limb volume change and you're also learning how to put the socket on. I know that water trick, and I didn't learn about that water trick until a couple of years ago, where somebody just said you pour water into it, and I'm just like, duh, there's suction. You put water in and it releases the suction. So yeah, great parlor trick there. Andrea says, I know Emily is working a lot on core strength, and that will help as the leaning forward can be an awkward angle. Yeah. Yeah. Okay. So this next one, I'm going to show you guys a picture. Ooh, did you guys know I'm doing a special? Like, I never do sales because it's expensive to do sales. I've got a sale for you guys. There, I'm putting it because my team would be very upset with me if I forgot to announce that. Okay, so guys, with my exercise program, Strong Body, Cosi Talks Strong Body, and we're actually going to go to it in a minute, and I'll show you a little bit more of what's in there. I'm holding a flash sale, and I'm going to tell you about that, okay? David says, once had the button for the pin lock fall out. Whoops. Okay, so the question that came in was this individual sent me a video about showing him at the gym squatting, and he looked like he was doing a pretty good job. He was a below the knee amputee, and he was saying, do I need to change something in my socket? I want to be able to squat lower. Okay, squat lower. So I'm actually going to go and share that they don't know if an amputee can squat. And I'm like, yes, you can. And I'm going to show you. It's in the video program. So my screen. Okay, here we go. Let's just get logged in. Okay, so I'm going to first do the below the knee one. I believe it was in phase 2. Let's go to phase 2, phase 2, phase 2. Got a lot of exercises in here, y'all. Aha, the squat. Here we go. All right, so I'm gonna let this play and I'm gonna let you guys listen to it. Now we're going to go over the traditional squat. I really love this exercise because it works so many different muscles. It's easy to do at home, and then you can also progress this exercise as you get stronger, okay? So for my below the knee amputees, sometimes my folks have a little bit of a hard time with the trim line in the front or in the back of their knee. So just do the squat itself within the limits that you have. You're going to be putting your feet shoulder width or slightly further apart. As Jessica's going down, she's not allowing her knees to go over her toes. She simply drops her bottom further down or sticks it further back in order to get the right positioning, and then pushing back up again. And then as she comes back up, she's going to be squeezing her glutes together to give her that power and to start really activating these glutes. So we're going to go back down again into the squat position so you can see the form, and then back out again. It's like mimicking sitting in a chair. That's how usually the easiest way folks can visualize what they need to do. You have to stick your bottom out back to allow everything to drop down, and then back up again. So once again, if you're starting out this exercise and you have some weakness, or if you're limited because of the trim lines on the front or the back of your prosthesis, then you can just do a mini squat. So you can just lower just a little bit and then back up again. And you can do and repeat this exercise until you get stronger and can go down a little bit lower. Give it a try. Okay, so there's that one. I'm going to show you guys the one for the above the knee as well, since we're already here. It's in phase 2. It's probably in phase 2 as well. Let me make sure. Here we go. Now, we're going to teach you the traditional squat. I know it doesn't sound very fancy, but this is one of the greatest exercises that you can do, especially when you're learning with your prosthesis how to do it. So in Jonathan's case, he does have a microprocessor knee and he's turned it off, so it's in kind of a free swing mode right now. So the first time you try this exercise, I encourage you to have a chair behind you in case you need to sit yourself down. So he's got his feet shoulder width, and you can even do it slightly bigger than shoulder width apart. He's going to go into a traditional squat. Here's the thing with traditional squat, very good. As you can see, Jonathan is doing it beautifully. He's taking his butt and he's sticking it out far back. He's not letting his knees come over his toes. All you're doing there is stressing out your knees. So it's the motion of sitting down into a chair. Down, and then. Okay guys, so you can see that hopefully that sound came through with the videos right there. Robin, I'm glad to have you here. Guys, did the sound on that go through? I'm always a little wary if I've done it properly or not. I'll wait for you guys to answer. Yes, it went through? Okay, awesome. Thank you guys. Okay, so as you can see, like, you can do a squat. And this is kind of one of those videos I've been meaning to post, because a lot of times people are just like, well, how can I do a squat again, especially for my above the knee amputees? And the answer is yes, you can do a squat. You might have to modify it just a little bit here and there, but it can be done. So in Jonathan's case, my above the knee amputee, he turned off the component of the microprocessor knee, so it was just a free swinging knee. And some above the knee amputees, they figure out how to work with the knee to allow them to go into that squat. Okay, so in some cases, with the below the knee, okay, and this is the particular individual who sent me his video, because he was squatting so low, right, he was coming up on the prosthetic toe because the prosthetic toe and the ankle will not bend the way an anatomical ankle will bend. So I think he was getting a little frustrated with not being able to bend down any lower. When I looked at his video, and again, hopefully he's watching this evening, he looked like he was squatting down pretty low. What I did notice is that he was squatting down very quickly and standing up very quickly. So if you're looking for an extra challenge in terms of your squat or even any of the exercises you're doing, and I always tell my people, slow down, right? So if you want that extra challenge with the squat, go ahead into the squat position, and when you reach that lowest position, hold it for 5 seconds. And then as you're standing back up again, think of yourself kind of like a rocket, right? You have to squeeze everything to really activate all of those muscles and go slowly up. Susan says, how do you stop oneself from putting all the weight in the sound leg? Very good question. Practice. So usually what I do, Susan, if I'm the therapist and I'm there in front of the person, sometimes I will use my hands on their pelvis. Come here, Bob. Right? And I'll put my hands on the side of their pelvis and gently guide them into loading that prosthesis, okay? If I feel like they're still really, really hesitant, then I will make the squat smaller. So instead of having the person go down into a full squat, I'll only have them squat just a little bit. Okay, so just enough so that they know they're going into the squat, but they have the confidence and they don't have that fear. Because a lot of times it has to do just with fear of loading that prosthesis. Okay. Okay. Or if the person does have a lot of weakness, then it just means that they have to squat in a little bit more shallow position until they learn and retrain their brains. That's one of my favorite token phrases. Learning how to retrain the brain to put the weight into that prosthetic side, okay? Some people will go as far as to take the trim lines down on their socket. Again, that is individual to each person. And now that hang on, let me show you the socket. Where'd it go? Here it is. Okay. So with the VK socket, some people will opt on the back side, on the posterior side, to perhaps trim it down just a little bit, and sometimes on the front part, the part that goes near the kneecap, right, to trim it down just a little bit. The problem is that the more you trim things down, right, the more you might be compromising the stability or of the actual socket. So that's a conversation for you to have with your prosthetist. But usually, people say, I want to really go down low on my squat. And it's like, guys, to get strengthening going, you don't need to go down all the way to the ground, right? You don't. And even if you watch some of these guys who are CrossFitters, when they're doing these crazy squats, their bottoms aren't touching the ground. Okay? It's about controlling the squat, doing it properly, and doing it with good mechanics. Let's see. Okay, and Susan says, just a little at first because I just tried it and it was totally putting all my weight on my sound leg. Sure. I mean, and that's a part of it. And actually, one of the talks I'm giving this weekend is specifically on how to make sure that you start really loading that prosthesis, right? So that loading it when you're doing the early gait training in your recovery, so that later on with other activities, you will, again, utilize your prosthetic leg, ideally as much as you use your sound leg. Okay. Guys, I think I covered all the questions this evening. So guys, that's what I forgot to tell you. Golly, boy, my brain is just going a mile a minute tonight. Okay, so for those of you who do not know about my Strong Body program, that's the one I just showed you right now. It's got 150 exercises for above the knee and below the knee amputees, and it's all exercises. You guys saw the screen right there. Arms, legs, core, balance, and flexibility, right? And then there are 2 books that go with it, an above the knee book and a below the knee book. So the book and the exercises ideally go together. Okay. So in gratitude, because you guys have been so wonderful about helping me with these polls and questions and social media participation, I'm doing a flash sale. So it started yesterday and it's going to run for 6 more days. So with the code COSI50, okay, you'll get 50% off the video subscription program. Okay, so go ahead, check it out, click it. I've had a few of you already start purchasing it the past couple of days. So you guys have about 5 days left on this sale. So get to it if you're thinking about it. Leanne says, Emily, please don't get discouraged. Donning a liner has a learning curve for everyone. It does. So much to learn, but you will get there. I heard you're in rehab at this time. Whenever you get a new gel liner, it can be a bit more challenging to put on. Your gel liner will become more pliable with time as you use it. Thank you, Leanne, and for those words of encouragement. And it's absolutely true. Those first few weeks of learning how to don a prosthesis, how to manage limb volume, can be incredibly frustrating. So Emily, you're in the right place. You're in inpatient rehab, so I'm glad that you are getting that guidance right now. Kesha asks, is your workout per month or a one-time thing, and does it come with a book or is that separate? The book and the program are sold separately. Okay. I recommend that you use them together, and the subscription to the video program gets you the program access for a full year. So usually it's like $59.95, $60. So now it's at $30. So for $30, you get the video subscription for the entire year. Okay. Pretty good deal, guys. Pretty good deal. Pam says, does the book come with it or only the video? It's only the videos. And guys, I really wish I could hold sales on the books, but printing is incredibly expensive. So the price on the book, it's separate because of that. And the price on the book is pretty much as low as I can price it. So, all right, guys. Thank you, Andrea. She says, I own both books as a therapist and they're awesome. Thank you again for that support. And guys, those of you who have purchased the book and the videos and you're telling your fellow amputees about it, truly appreciate the support. And thank you. Susan, I remember that email, but I never got the follow-up answer from you, which I thought was strange because I remember sending you the information for the shipping because there was an issue with the shipping, right? But I didn't hear back from you. So please resend that to me again. Thank you, Pam. I think so. All right, guys. I have talked myself out this evening. All right, guys. Lots of stuff for this next couple of weeks. We've got a sponsored show next week. Next week, we have Integrum coming on board for our Veterans Day special. And then the following week, my boy Reggie Showers is coming into Tampa. And you know it's always a good time with Reggie Showers. All right, guys. So, boy, I'm got my frog in my throat right now. Excuse me, guys. All right, I'm going to go because I got to go pack for my trip. Keep an eye on my social media, guys. We've got fun stuff I'm doing this weekend with the Discover Your Possible with Mission Gate. And then also got some polls and questions that I need your help in answering. So guys, keep your eyes peeled for that. As always, thank you for letting me be a part of your lives this evening. And I will see some of you this weekend. And the rest of you, I will see next week. Same bat time, same bat channel.